Hello everyone, this is Adam again, and today we're going to be covering our final section of cardiology medications. These will be mainly covering the antiarrhythmics. So just a review of some cardiac physiology in regards to normal electrical conduction throughout the heart. We know that the cardiac muscle is striated in nature. We know that some of the tissue is going to have automaticity, especially when you talk about some of the nodes that has more automaticity than some of the other myocytes. We see that usually electrical conduction is going to be kind of this all or none phenomenon. So in a lot of cases you need to hit a certain electrical potential in order for the myocytes to contract. You have this kind of idea of these intercalated discs that allow the conduction to occur amongst various cells. So it's kind of a nice way for the cells to kind of communicate to one another, and they kind of form this functional syncytium. It's kind of this nice fancy term for how the heart's able to kind of contract in unison and kind of have your contraction happen from the atria down to the ventricles in order for blood to flow in an organized manner. For the conduction system to work appropriately, it has to go through these specialized cardiac cells, these ones that will have various degrees of automaticity. So starting out with the SA node, the sinoatrial node, then going down to the atrioventricular node, or AV node, and then it will then travel through the bundle of His and these Purkinje fibers in order to allow the signal to transmit through the ventricles to cause that squeeze to let blood flow out of the heart. You see here how it will travel, the signal will travel basically from the top of the heart down. It's important to remember that even if you didn't have an SA node, the AV node will still have some degree of automaticity. So you can still get some sort of regular heartbeat from that, and you would see that the Purkinje fibers and the bundle of His have even less automaticity than that, but still to have some degree of it. But really once that first signal hits from the SA node down to the AV node, that's really that all or none phenomenon. That's going to be the contraction that you're going for. We can see here that your SA node and the AV node, they have that degree of automaticity because they're kind of these leaky channels. They allow for a kind of a slow influx of sodium that allow it to reach a certain potential, and then that will kick off the action potential. So you can see here the SA node will have kind of a slow leak. Once it hits a certain potential, you'll have your action potential begin, and then you'll have things like the atrial muscle who have no degree of automaticity. They're just going to sit there and wait until they have that signal come in. And so that's what's going to, the signal from the SA node will trigger off the atrial muscle, and then your AV node will be hit as well. So that's kind of where we see our big P wave coming in from the atrial muscle. Then as it travels down through the common bundle and the bundle branches, that's where we're seeing our QRS wave, as we're seeing the ventricles actually contract, and then you have your T wave where everything's kind of resetting itself, getting ready for the next beat to occur. So this graph here kind of shows you a cell that has no automaticity, or these fast response cells, kind of what's happening when they're being triggered. So if you're looking at phase 0, that's when you have, if action potential comes along and triggers the cell to contract. Initially you're going to have that phase 0 where you have that inward sodium current. This will be a big site where a lot of antiarrhythmics could be working to slow inward influx of that sodium, but we'll talk about that later. And then during phase 1, you're going to have some lowering of that membrane potential by having outward flow of potassium. So again, positive is leaving the cell, so it's going to lower your membrane potential, and then you'll actually have inward flow of chloride, which again will make the cell more negative. Phase 2, you see kind of a plateau effect, and that's mainly due to this inward flux of calcium. So again, you'll be making the cell a little bit more positive, even though you have kind of this inward flow of chloride. And then for phase 3, you have more outward flow of potassium, which is going to be setting up basically kind of resetting the cell, getting it ready for the next contraction. This is where we see kind of our refractory periods come in. Outward flow of potassium is also where you can see drugs that affect the QTC interval being affected as well, which we'll talk about a little bit later. And then for phase 4, that's where you have the sodium potassium ATPase pump really working in order to kind of maintain a normal electrical potential for those cells so that they can be triggered again later by one of the cells that has automaticity to it. So we mentioned that sodium potassium ATPase pump being really important with the mechanism of action of digoxin, and so this transporter is really necessary in order to maintain normal electrical potential for the cells by pumping sodium and potassium against its concentration gradient. So sodium will be shuttled out of the cell because again, the serum sodium level is, say 135 or something like that, on a normal level. Pumping sodium out of the cell is going against the concentration gradient, and vice versa. Potassium coming into the cell is against its concentration gradient. So that's why you need that ATPase to function and use active energy in order to make that balance work. So this is just another graph to kind of show you the flow of electrolytes during a, say, ventricular action potential. Kind of show you some animations to give you a better idea of how things are kind of moving around within the actual myocyte. So phase 0, this is where you have that rapid influx of sodium to lead to that big jump in your membrane potential. Notice here that the channels don't stay open for very long. They cause a big influx of sodium along its concentration gradient, and then they close fairly rapidly. And then for phase 1, where you have that little downward trend in your action potential, this is where you're going to be seeing potassium flowing out of the cell, and then you also have chloride flowing into the cell. Next up, you're going to be seeing the plateau effect occurring here due to calcium flowing into the cell. So even though the cell is trying to get back to that negative potential, the influx of calcium maintains that positivity, and so you have that plateau effect occurring here. And then during phase 3, this is where you're going to mainly be seeing potassium being shuttled out of the cell in order to start to reestablish that electronegativity. And then obviously your sodium potassium ATPase pump is maintaining that at a normal resting membrane potential, say like -90 millivolts. Again, just another picture kind of showing you some of the different channels that are going to be responsible for allowing the myocyte to contract. So you see on that first section there, you see a big influx of sodium, and then really sodium is going to be dipping down on pretty minimal activity. If you guys remember our L-type calcium channels, that's where a lot of our calcium channel blockers are going to be working specifically. So you can see that calcium influx there, especially during phase 1 and 2. And then the other thing to really note here is that inward rectifier, that IK channel, that's going to be really important when we're talking about QTC prolongation, because things that are blocking that inward rectifier are going to allow for QTC prolongation and delays that resetting of the myocytes that allow for some of those reinsurant rhythms like torsades. So it's important to realize that cardiac cells, they have a refractory period. So there's basically two different types of refractory periods, one being absolute, meaning that no matter what type of signal comes along to try to trigger that cell, it's in a state where it simply cannot contract again. Right, so usually this is going to be earlier on during the depolarization. Then you have a relative refractory period where you're a little bit farther along in kind of resetting the cell, getting it ready for the next action potential, but a strong enough signal could come along and potentially re-trigger it to start up say a reentrant rhythm. So here's what our slow response cells look like our SA and our AV nodes. These are the ones that have the automaticity that allow for normal cardiac conduction to occur via these action potentials, because they're the ones that are generating the initial action potential itself. If you notice here, you kind of see this this leaky sodium current. If you look at phase 4, certainly you have the sodium potassium ATPase pump helping to retain some degree of electronegativity, but you have this kind of leaky inward amount of sodium coming in, and so that's what's kind of leading that gentle creep up in membrane potential that you see there. Once you hit a certain threshold, then phase 0 occurs where you have inward flux of calcium. And again, this is where you're going to see a lot of your non-dihydropyridines working, like your diltiazem and verapamils, because they're able to block the inward flow of calcium there. And then it goes into phase 2, where you still have some degree of calcium coming into the cell, but you have a lot of outward flux of potassium. And then finally with phase 3, when you're resetting those pacemaker cells, you have just the outward flux of potassium. And then you get back to your baseline in phase 4, where you just have the sodium potassium ATPase pump trying to reset everything, with that leaky sodium current allowing for some slow creep up and increase of membrane potential. So here, just another slide kind of showing you the animations of how the electrolytes are flowing during the action potential generation. So during phase 0, you're going to see that calcium influx, and during phase 2, you're also going to have some continued influx of calcium, but it's going to be relatively lowered in comparison to the potassium, which is mainly going to be going in an outward trend in order to allow for the resetting of that cell. And then during that phase 4, again, you're just having your kind of resetting of the cell with the sodium-potassium ATPase pump with that slow inward flux of sodium, allowing for that slow creep to get to the action potential point. So this is kind of an interesting point. So we all know that how the sympathetic and the parasympathetic nervous system work. On the heart specifically, say if you were to have an adrenergic effect on the heart, so you're releasing catecholamines like norepinephrine onto the beta receptors in the heart, you expect to have an increase in heart rate. And if you think about how that actually works in regards to how it changes electrolyte conductance, one thing that it does is it actually decreases potassium conductance. You wonder, like, okay, well, how does that increase heart rate? And if you think about it, working with these pacemaker cells, we saw that outward flux of potassium led to resetting of these cells and allows it to go more electronegative. Decreases that membrane potential. Or if I were to decrease the outward flow of potassium, all of a sudden I'm starting to raise my membrane potential higher than it would be normally, and that allows you to reach that trigger point or that action potential point even sooner. So you need less time for that sodium, that leaky inward sodium flow to really hit that action potential point. So as you might imagine, if you're at a higher baseline, you're closer to hitting an action potential, it's going to happen more quickly, and thus you're going to see faster heart rate. And on the other side, if I were to activate the muscarinic receptors from the cholinergic effects, acetylcholine hits the muscarinic receptors, you'd expect heart rate to go down. And so that makes sense as well, because these cholinergic effects will actually increase outward flux of potassium, and that would actually make you have a lower resting membrane potential, and thus it would be more difficult or take longer time for that inward flux of sodium to hit the action potential point. So in which case it would end up slowing down the heart rate because it would take longer in order for you to trigger off that action potential. So in those ways, you can kind of see how both the adrenergic and the cholinergic effects can directly affect the heart rate only through potassium conductance. So there's lots of different mechanisms for how these arrhythmias are going to arise. Kind of can be broken down into either abnormal impulse formation or abnormal impulse conduction. So for instance, with the impulse formation, if you have altered automaticity, so say if you were to have something like an ectopic pacemaker, that can be one issue where that's kind of setting up a new rhythm for the heart, which could lead to some arrhythmias. After depolarizations, which can be broken down to early or late after depolarizations, are usually due to issues with certain flux of ions like calcium or potassium not being handled appropriately. And then you can also have abnormal impulse conduction. And so you see this a lot, especially when you have patients who have had previous areas of infarction on the heart, because we know that ischemic areas tend to conduct electricity slower than healthy tissue would. And so it's easy for the ischemic tissue, because it's slowed, you can end up having these reentrant rhythms start up due to the fact that the different refractory periods are going to be varied between the healthy tissue to the ischemic tissue. You can also have things like unidirectional blocks occur as well here, especially if you were to have say an area of infarction in just one ventricle versus the other. So here I'm not going to get into too much detail describing all the different arrhythmias that could possibly pop up, because honestly that's not my forte. But one of the things I will mention here is that it's important to realize where your different antiarrhythmics may be of benefit. You'll see that certain drugs are going to be better for purely ventricular arrhythmias. So if you were to have VFib, VTAC, torsades, it's going to be better for that, versus if it's ones that are more originating in the atria, you may be using different drugs for that. So something like things that work directly on the nodal tissue to slow conduction between the atria and the ventricle. So you'll kind of get an idea of the differentiations there, and so it'd be important to remember some of those details, especially in regards to just the mechanism of how they're going to be working specifically. So the principle of therapy with antiarrhythmic drugs is, one, you want to try to remove any of the precipitating factors and at least identify them if possible. So if the issue is hypoxia or ischemia, hopefully you've dealt with that. If the issue is electrolytes, either too much or too little of particular electrolytes, hopefully you can take care of that as well, whether it be by replacing certain electrolytes or dialysis to get rid of other ones, whatever happens to be. Try to identify those kind of precipitating factors, because there's no point in treating with drugs if you can't fix those first, or if you can't at least identify them and try to reverse the ones you can. After that, you want to at least establish your goals of therapy. So, do you want to have the prevention of arrhythmia, or do you want to have termination of an ongoing arrhythmia? It's good questions to have. You're looking at things like symptoms, frequency, and reproducibility, along with the actual heart structural damage. It may not be possible to always have prevention of arrhythmia, but at least you can try to target different goals for your patient that you guys can both agree on. You want to minimize risk because we know that all antiarrhythmics can actually induce their own arrhythmias. So it's important to understand the mechanism there of why that is, so that hopefully you can minimize the risk for particular patients based on their comorbid disease states and other factors. And then just keep in mind that the electrophysiology of the heart is really a moving target. So because of the fact that ischemia can alter resting membrane potential, conduction velocity, and intracellular calcium repolarization rate, what may work for a patient at one point may not always work for them later on, especially if they have ongoing ischemia, especially to other issues that pop up. So keep in mind that you may need to further tailor therapy as things change for your patient over time. So the way that we're going to be categorizing our antiarrhythmic drugs, and you'll see there's a Vaughan Williams classification for our different antiarrhythmics. But first off, we're going to be looking at our sodium channel blockers. These are going to work specifically by decreasing excitability. So if you have less sodium influx, you're going to have, you're going to have less automaticity from the SA and the AV nodes, but you're also going to have less sodium influx on those fast response cells, leading to decreased contraction there. We can actually prolong action potentials and hopefully prolong that refractory period and prevent some reentrant rhythms by blocking potassium channels. We've talked about that when we saw QTC prolonging drugs. We can also work on beta receptor blockade. So by prolonging the AV refractoriness and prolonging conduction, you're going to increase the actual energy that's required for you going into something like atrial fibrillation and things like that. And then we're also going to see calcium channel blockers working similarly to slow down the conduction of the slow response cells and decrease their excitability. So the classification, again, as I said, this is that Vaughan Williams classification of antiarrhythmics. We'll have our class 1 drugs, which are our sodium channel blockers, and those can be broken up into 3 different classes. So it'll be 1A, 1B, and 1C. So we'll talk more about those and how they're going to be working a little bit differently from one another in a second. We'll have our class 2, which will be our beta receptor antagonists. So you guys already know how to identify those and are pretty familiar with them. We'll have our class 3 agents, which will be another group of new drugs that will help to prolong repolarization, specifically by blocking those potassium channels. We'll have our calcium channel blockers being our class 4, and then we'll have kind of a mixed bag of other antiarrhythmics we'll see being used, things like adenosine and digitalis. So this slide can be a little intimidating, but once you have a better idea of the mechanisms of actions of the various drugs, it'll make a little bit more sense on why you can use different antiarrhythmics for different arrhythmias. Big thing to note here, class 2 and your class 4 antiarrhythmics, so your beta blockers and your calcium channel blockers specifically, are going to be more useful for things that are having rapid conduction through the SA and the AV node to the ventricle. So if you think about like your supraventricular tachycardias, your A-flutter, like 1-to-1 conduction, those are going to be better things that can be served by treating them with your class 2 and your 4 antiarrhythmics because they're working directly on that nodal tissue. A lot of your miscellaneous agents will also fall into that category as well, but we'll talk about those as we get to them. Your class 1, 1A, 1B, and 1C, and also your class 3 antiarrhythmics are going to be useful for supraventricular tachycardias as well, but you can also use those for things like AFib. You can also use them for arrhythmias that are generating in the ventricle. So if you're having VTAC, VFib, those could all be treated by your class 1 and your 3 agents as well. So the first group we'll look at are going to be our sodium channel blockers. And so looking at the normal function of our sodium channels in, say, our fast response cells, so the ones without automaticity, you can see here that the cells, the resting state of the membrane prevents sodium from influxing into the actual myocyte. And so you reach a certain threshold. Once you hit that point, then all of a sudden you have these activated sodium channels which will open up and allow inward flux of sodium. So that's where you have that big jump in your action potential or your just your membrane potential in general. And then now you have this inactivated phase where you see this other portion of the channel actually come in and close off further flux of sodium. So even though the channel has not reached back to that resting state, it's still able to block inward flux of sodium. So we'll see where our 3 different classes of sodium channel blockers are going to work a little bit differently on those channels. So the first ones are going to be our class 1A antiarrhythmics. So like we said, by blocking sodium channels, they're going to slow phase 0. They're going to allow less sodium to go in, or at least come in at a slowed rate. So they help to slow conduction. They're going to prolong the action potential. And here you're going to see that they have an affinity for the open channel more so than the inactivated channel. So once the channel is open, these drugs can get in there and actually block further sodium influx. So they prefer to be in the open channel, and they dissociate fairly slowly, so they don't come out of that channel as quickly as you will see with some of the other agents. So the first 1A sodium channel blocker we'll talk about is going to be quinidine, which is actually the D-Isomer of quinine. Quinine is an old school anti-malarial that used to be used a long time ago. And if you're ever curious why your gin and tonics glow in a black light, like here you can see this tonic water glowing, that's actually due to the quinine content causing that to occur. So little factoid there for you. Now this drug is going to work by slowing conduction. We saw this going to prolong the refractory period, so it can help to prevent some of those reentrant rhythms from coming in, especially when you have that ischemic tissue kind of having slower conduction than your healthier tissue. It's going to slow that rate of rise of phase 0 and will increase the threshold for excitability. So it takes a stronger action potential to come along and actually trigger off that cell to have an action potential. And will help to decrease automaticity in your SA and AV nodes as well. Some of the other things, you can actually see some indirect actions. It has some anticholinergic effects, which you may think, is kind of counterproductive because you'd actually be increasing heart rate at that point, but it's just some ancillary effects you see there. And then also has some alpha blocking effects at higher doses. So you may actually see some effects on the blood pressure due to that. So you might use quinidine to maintain rhythm. If you have a patient who has maybe atrial flutter or fibrillation, it can help to prevent recurrence of aflutter or fib. It can help to control ventricular tachycardia because, again, it wouldn't be working just specifically on the nodal tissue, so it's able to work either in the atria or the ventricles. And in some limited cases, you might actually see it being used for chemical cardioversion of AFib and AFlutter. Again, not used very frequently. Oftentimes it would be used with other things like anticoagulants to prevent throwing a clot, which may be developing in an atria that's having AFib or flutter. Other things to note, though, is that it's actually a CYP2D6 inhibitor. So this can be important for various medications such as codeine or morphine, which are opioid analgesics. You'd actually inhibit the metabolism of those drugs and actually lead to further analgesic effects from them, which could be a problem, especially if you have more respiratory depressant effects and things like that on board. So just be aware and make sure you check your interactions prior to prescribing. So there's also a lot of toxicities of quinidine, which is probably one of the reasons we don't use it very frequently. Some of the things you're going to be seeing, nausea, vomiting, diarrhea are very frequently associated with quinidine, so 30 to 50%. As we said, any of these drugs can induce their own arrhythmias, so certainly arrhythmias could occur either in the ventricles or the atria. We said the alpha blocking effects could lead to hypotension, and then you can also see that thrombocytopenia, although it may be rare, could be fatal in some cases. Now, there's this other constellation of signs and symptoms that can occur from quinidine. So this would be synchronism, and so you can see the same thing with quinidine or quinine as well. But basically, you have tinnitus, dizziness, and blurred vision that can occur from this. You would also have this quinidine sudden death syndrome, which is thought to be due to torsades or other ventricular arrhythmias which can occur. So just be aware, because anytime you're decreasing or kind of prolonging that action potential, you always run the risk of having those reentrant ventricular arrhythmias. So something like torsade could be a possibility there. So again, pretty toxic drug, but again, if it's if it's the only thing that's going to work for that particular arrhythmia, it may be better off for your patient. So it's a real big risk versus benefit analysis you have to run there. So we have better drugs nowadays. So there's a reason why we don't use drugs like quinidine very frequently anymore. Another drug for this category is going to be procainamide. This is actually an amide derivative of Procaine, which is a local anesthetic, which we'll talk about later on in the class. This one has a fairly short duration of action. They actually have some slow release preparations or extended release preparations. The nice thing about this is that you will see it has less anticholinergic activity and less alpha blocking activity than something like quinidine did. But you also have this byproduct, this NAPA. And so it's an active acetylated metabolite that actually has some class 3 activity, so it'll have some ability to block potassium channels as well. For patients who are fast acetylators, remember that some patients will be slow acetylators, some will be fast. You can actually see that if they're fast acetylators, they'll actually have an increased proportion of this NAPA being produced, which can potentially lead to some issues with arrhythmias and whatnot. So some adverse effects we can see hypotension, slowing of conduction. For patients who are slow acetylators, this is another drug which can potentially cause that lupus-like syndrome that I remember seeing with the drug hydralazine. So around 25 to 50% of patients may develop this. Obviously torsades is another potential here, potentially bone marrow suppression. You see that as far as if you're going to use this for something like chemical cardioversion, IV would be better tolerated than quinidine, but orally it's not really tolerated all that well in the long term. And the final 1A antiarrhythmic we have here is going to be disopyramide. You'll see that the effects are pretty similar to quinidine here. It does have more anticholinergic effects and will have some negative inotropic effects on the heart itself, so you can decrease contractility there due to that. As far as indications, again, you'll see things like ventricular tachycardias, but also supraventricular arrhythmias as well could be used for this. Remember, your class 1 antiarrhythmics could be used for either atrial or ventricular arrhythmias. Toxicity is going to be fairly similar to what we saw with quinidine. You can see some hypotension, some antimuscarinic effects. Due to that decreased contractility, you could have potentially worsening congestive heart failure, and then also torsades is another risk here. And if you had a patient who had a heart block, you would definitely want to avoid this. And then also if they have glaucoma, you could potentially worsen this due to some of the antimuscarinic effects you can see there. So the way I remember the 1A antiarrhythmics is by using the acronym PDQ. So Procainamide, Disopyramide, and Quinidine. It's just the way I help myself to remember it. Moving on, then you have your 1B antiarrhythmics. These are going to work to shorten the phase 3 of the action potential, and they will help to decrease ectopic foci automaticity. So this is going to be beneficial for patients who have areas of ischemic tissue, because what you'll actually see is that while they target the inactivated sodium channels, they actually have a higher affinity in ischemic tissue and don't really affect normal tissue so much. They're also going to have pretty rapid dissociation from the channel here, as opposed to like what we saw with the 1A antiarrhythmics. So the first drug we'll talk about for the 1B antiarrhythmics is going to be Lidocaine. I'm sure a lot of you guys have heard of this one before. This is another local anesthetic. You see used a lot for numbing up areas for like procedures like sutures and things like that. But you can also give it intravenously to treat some of these arrhythmias like Wolff-Parkinson-White, ventricular tachycardias with premature beats, VFib, and even in acute MI if you're having some ventricular arrhythmias there. So lidocaine itself has to be given IV because it has a pretty extensive first pass metabolism, so it really wouldn't be absorbed via the oral route. Now, like we said, it's going to bind to the open or inactivated channels, and the recovery is going to be pretty rapid from that. But like we said, it's going to be more effective on the sodium channels in the ischemic tissue. So it'll be better for those patients who are having like an MI who has an actively ischemic tissue happening in the heart. Again, this will be typically not super effective against atrial arrhythmias, but it'll certainly be much better for some of your ventricular arrhythmias. As far as toxicity goes, you can see quite a bit of CNS toxicity, especially if you have patients who have poor hepatic function. They're not able to clear the drug effectively. So you can see things like drowsiness, confusion, muscle twitches, nystagmus, which can actually be an early sign of toxicity, which might let you know that, hey, maybe we're giving too much to this patient. Hypersensitivity can happen, but it's not super common. And then obviously, because seizures are a possibility here as well, if they have previous history of seizures, you may be lowering your seizure threshold, maybe inducing that for your patients. Another drug here is Mexiletine, which is an analog of lidocaine. This one does have some oral availability. Here again, you're going to see decreased automaticity, decreased conduction of the ventricles, and you can actually see it being used for patients who have a congenital prolonged QT syndrome. So it may be useful for them to help decrease the automaticity to help prevent sudden cardiac death due to torsades. As far as side effects go, again, nausea, vomiting, tremor possible here. You see similar CNS effects as you would see to lidocaine, and rarely you may see some blood dyscrasias. So changes in granulocytes and platelets and things like that. So those are the two class 1B sodium channel blockers, and then finally we have the 1C sodium channel blockers. These are going to be slowing phase 0, slowing conduction, and prolonging that refractory period, and this will affect normal heart tissue. And here you're going to see that it's also going to be affecting the open channels more so than the inactivated channels, and its dissociation is going to be very slow. Flecainide is going to be the first one we'll talk about here. So again, this is going to be working on blocking sodium channels. This one can also have some class 3 activity where it blocks potassium channels in the ventricles as well. So you're going to see it prolong the PR, QRS, and the QT intervals as well. Has a fairly long half-life, so is a good as an oral agent, but could also be an IV potentially. And sometimes it will actually be used to prevent premature ventricular contractions. So the indications for this would be life-threatening sustained ventricular arrhythmias, supraventricular arrhythmias, so you can see here working both in the ventricles and in the atria. It really should only be used for patients without significant structural heart damage, because I've actually seen some bad outcomes for patients that do have that using Flecainide. As far as toxicity goes, blurred vision, tremor you can see with this drug. You can actually end up inducing a ventricular tachycardia, and because you have this drug on board blocking the sodium channels, it can actually be resistant to other treatment, which can be a problem, obviously. The bronchospasm, seizures, thrombocytopenia are possible, and then like I mentioned with that structural heart disease, you actually have patients have increased mortality in MI, so it'd be one you'd want to avoid in those patients. You also have Propafenone, which has a very similar mechanism to Flecainide. This one also has a little bit of beta blocking activity, so it can work on the automaticity in SA and AV node as well. As you mentioned, this can be a proarrhythmic as well, similar to Flecainide. Very similar side effects, but you also see some bradycardia here as well, and even potentially some bronchospasm due to having kind of non-selective beta blocking activity. Again, because you're having decreased contractility due to the beta blocking effects, you can actually have worsening CHF for your patients if they have that already. Next, we'll have our beta blockers. Again, we know a lot about these drugs. They're mainly going to be working to slow conduction and decrease automaticity and help to prolong that AV nodal conduction. And also they can work to decrease that phase 4 depolarization as well. Propranolol probably being one of the more common ones. Again, this is a non-selective beta blocker. Helps slow that AV conduction, reducing that phase 4 activation, and have negative inotropic and chronotropic effects on the heart. So decreased speed and also the contractility of the heart. This can be useful for suppressing some PVCs. And then also this one specifically has a membrane stabilizing effect. We kind of mentioned that a little bit when we talked about beta blockers previously, but some believe that this stabilizing the membrane kind of helps to prevent some arrhythmias in these cases. So we can see it being used for supraventricular arrhythmias. If you're having ventricular ectopic beats, and also in the case of myocardial infarction, we talked about it being useful there, especially for some of the mortality benefits you can see. So certainly worsening heart failure could be an issue here with our beta blockers. You can see heart block, hypotension, hyperglycemia, bronchospasm. We kind of talked about all of these previously. So same toxicities are going to apply here as well. Again, metoprolol being just kind of a representative beta 1 selective blocker. Again, here you're going to see that less bronchospasm here. Another good one you can actually use IV, which we mentioned previously, is going to be the esmolol, which is usually given by an continuous IV infusion because it is a short-acting agent. So it can be really useful if you're having an SVT, kind of help decrease that ventricular rate, kind of get it back down to a normal rhythm. Moving on, we have our class 3 antiarrhythmics. So again, these are going to be our potassium blockers. So they're going to help to prolong repolarization. And this is mainly due to this potassium efflux coming out and towards that phase 3. So again, these are going to prolong phase 3 repolarization, helps to prolong the refractory period and prolong the duration of the action potential itself. So out of the antiarrhythmics you're going to see being used for control of ventricular arrhythmias or things like AFib and aflutter, you're probably going to see class 3 antiarrhythmics being used most frequently. The first one we'll mention here is amiodarone. There's both oral and IV formulations, and actually an analog of thyroid hormone, which will be interesting when we look at some of the side effects here. This drug has a very long half-life. Average is about 40 days. but can range anywhere from 26 to 107. So has a very slow onset and slow elimination. So in order to overcome that and to try to get to a faster steady state, because I mentioned 4 to 5 half-lives just to get to steady state, that could take a long time. So in order to kind of get over that, we go ahead and give loading doses of the drug in order to get them at a steady state level, and then get the maintenance doses afterwards. So our indications could be recurrent ventricular tachycardias or fibrillation resistant to other drugs. It's good to maintain normal rate in AFib. And then if you're giving IV, it's actually can be used to terminate acute ventricular tachycardias or fibrillation. In a lot of cases, you see it replacing lidocaine in MI. If you look at your ACLS guidelines, you'll actually see that lidocaine used to be a little bit more frequently recommended, but nowadays amiodarone is kind of like your go-to antiarrhythmic for ventricular arrhythmias during codes. So it's going to work to not only block those potassium channels, but it can also work to block inactivated sodium channels, blocks calcium channels, blocks alpha and beta receptors. And so by doing all this, helps decrease automaticity, conduction, and prolongs that refractory period. So imagine if you have like a ventricular tachycardia or fibrillation, by slowing down that refractory period and decreasing that conduction, you can end up having slowing of that ventricular rhythm to try to allow for normal conduction again. Unfortunately, amiodarone has quite a bit of toxicity associated with it, especially with chronic use of the drug. So certainly you can see some hypotension from those alpha and beta effects, but you can also see some pulmonary effects that can occur over the course of months to years. You have a pneumonitis and pulmonary fibrosis, which could potentially be fatal, especially if it's not caught early on. You can have some neurotoxicity like neuropathies and muscle weakness. And then another thing you can see, due to the drug depositing in the skin, you can get this blue-gray skin discoloration that can occur and some photosensitivity. Because it's an analog of thyroid hormone, you can either see hyper or hypothyroidism that can develop from this, and you also worry about some hepatic dysfunction. You can also see some interactions with things like increasing digoxin concentrations, warfarin levels, flecainide, phenytoin, and even procainamide. So it can have an interaction with quite a few drugs. So it's good to check that out, make sure you're not going to have any pharmacokinetic interactions there. Another class 3 antiarrhythmic will be ibutylide. This is going to, again, prolong the opening of those potassium channels or decrease that efflux, but also affect the inward sodium channels, and is going to work to prolong repolarization and prolong the action potential. You can see this being used primarily as a way to convert chemically either AFib or A-flutter. You can see here the various success rates you're going to see with that. Due to that blocking of the potassium channels, you can actually end up seeing prolongation of that QT interval, and that's where torsades risk comes from. And also heart block can be another issue here. So mainly you're going to see it used IV. You won't see it used for more chronic management typically. A newer drug added on to this class 3 group is going to be dofetilide or Ticasin. Kind of rapidly seeing this become a much more frequently prescribed drug, especially my wife, she used to work over at the VA. A lot of vets were being placed on this drug due to prevention of either maintaining normal rhythm in AFib. We also had some good effects on preventing ventricular arrhythmias, so it was kind of becoming more and more recommended. But it does have quite a bit of adverse effects associated with it, and some things you have to watch out for. So torsades obviously being the biggest risk, just due to the fact that it's blocking those potassium channels, and you can see some pretty marked QT prolongation. So it's super important to make sure that you're doing EKGs beforehand, do EKGs after you change any of your doses to make sure that you're not having too big a prolongation there. And the other big thing is it's eliminated in the kidneys, so it's important to make sure you're monitoring kidney function, make sure you're monitoring different electrolytes, because if you are if you don't get a baseline, say complete metabolic panel, and they have elevated potassium or decreased magnesium or anything like that, it's out of whack, it can really increase their risk for having torsades and other arrhythmias. So it's important to really check your electrolytes, check your EKGs, and make sure you're checking renal function anytime you're prescribing Ticasin. Another agent, this is sotalol, otherwise known as beta-pace. It's actually a beta blocker, so you'd think it would fit into category 2, but it actually is going to be category 4, because even though it does have your beta blocking activity, it will also inhibit these potassium channels. So this is kind of a unique beta blocker in the fact that it does inhibit those potassium channels and can be used for ventricular arrhythmias along with AFib and A-flutter. Very similar toxicity as you would see with other beta blockers that are non-selective, but just keep in mind that this one also has the potential to cause torsades due to those potassium blocking effects. We have our class 4 antiarrhythmics, which will be our calcium channel blockers. We know these are going to block those L-type calcium channels, slow AV nodal conduction, have negative inotropic effects, and decrease automaticity. So obviously verapamil and diltiazem are going to be the only two we're talking about here, because really only the non-dihydropyridines are considered to be in this category. Our dihydropyridines are primarily working on the vasculature, not really having a whole lot of effect here on the heart. So it's going to block both activated and inactivated channels. It's most effective in active tissue. So if you were having, say, a reentrant rhythm somewhere in the ectopic foci, say up in the atria, that's more active than, say, the SA or AV node is, then it would actually be a little bit more effective there because that has a more active turnover of calcium. It's going to decrease AV conduction and suppress the SA node as well. So most often you're going to see this being used for control of AFib, especially kind of controlling ventricular rhythm and SVTs as well. And we know that all the side effects we're going to be worrying about here, 3A4 inhibition, issues with hypotension, edema. So those the same side effects you'd be worried about here as you would any other indication. Next we have some miscellaneous agents we'll talk about briefly. So adenosine is a natural product your body makes pretty consistently. It's a major inhibitory type of molecule. In the CNS, it prevents seizures by activating adenosine receptors. Here in the heart, you're going to see it be a major inhibitor on the heart as well, because you're activating potassium channels in the atria and will actually block calcium channels. So by opening those potassium channels, you're going to allow a lot of efflux. You're going to kind of hyperpolarize the cell and prevent them from being re-triggered again. So what you actually end up seeing when you give it is you're going to be decreasing conduction velocity and may actually stop the heart for 2 to 3 seconds when you give it. So by doing that, if you're having, say, like a supraventricular arrhythmia that's being very difficult to control, you can actually give this to basically stop everything in the heart, allow it to kind of reset itself, and then have a normal rhythm again. So it's kind of scary when you give a drug and causes asystole for a few seconds, but hopefully because the drug has a very short half-life of around 10 seconds, everything should come back to normal when you come back. So either they'll go back into SVT or they will go back into a normal rhythm, which you're hoping for. So most often you can see it used for Wolff-Parkinson-White, but more frequently for paroxysmal supraventricular tachycardias. As far as toxicity goes, patients are going to feel pretty crummy when they receive this because you're kind of stopping the heart for them. They can flushing pretty frequently, shortness of breath, and also burning in the chest. It's really important to make sure that this drug, because it has such a short half-life, is going to be administered appropriately. So what I mean by that is if I'm giving this in a peripheral vein and I just go ahead and just push the drug in at a leisurely pace, most of it's going to be metabolized before it even gets to the heart. So it's really important that this drug be pushed as quickly as possible and then be flushed behind it very quickly. So most frequently you'll see it be used with a three-way stopcock, where will push the drug in very quickly, and then you'll have like a 10 ml flush behind it just to try to get the drug through the veins to the heart as soon as possible. Another miscellaneous antiarrhythmic will be digitalis, otherwise known as digoxin. We talked about this previously, how it works as a sodium-potassium ATPase inhibitor. Here you'll see it working to slow AV conduction, will inhibit some of those calcium channels in the AV node, and will, like we said for CHF, increase parasympathetic tone and decrease the sympathetic tone. Frequently you're not using it as an antiarrhythmic specifically, but more frequently for those neurohormonal effects on the nervous system. As an antiarrhythmic, digoxin can be used to slow the ventricular rate and to induce a heart block, which would be useful for things like A-flutter or AFib. And we talked a lot about the CNS toxicity you can see from this, like having confusion, yellowing vision, halos, things like that. And typically, because of the heart block issue, you want to avoid using it in combination with the calcium channel blockers, beta blockers, unless you are kind of carefully titrating those doses to make sure that you're not going to have too big of a decrease in activity of the nodal tissue. Our final antiarrhythmic is going to be magnesium sulfate. mostly you guys know it as an electrolyte, but can be given as the treatment of choice in torsades. Essentially, basically, you slam the patient with 1 to 2 grams in order to help kind of get them out of that rhythm. You can think of magnesium as kind of like the body's natural calcium channel blocker, and so you can see some very similar effects to that. So you can see some bradycardia, some flushing due to some vasodilation, hypotension is possible, and even potentially respiratory paralysis. Even that's pretty rare. Would only be seen with really, really high doses. Other than that, that's basically your antiarrhythmics. If you have any questions, please feel free to send those to me. Otherwise, we'll talk in class next time. See you guys. Thanks so much. Bye.